And then we're going to talk about infections, brain tumors, and we are going to conclude with epilepsy and the other seizure disorders. Okay, so let's start with mechanisms of brain injury and increased intracranial pressure. So brain injury can result from trauma, brain infection, cancerous or benign tumors, or other degenerative processes such as Alzheimer's disease. The brain damage involves several common pathways: hypoxic and ischemic injury, excitatory amino acid injury, and cerebral edema. Hypoxic injury is a result of low oxygen, such as might occur with high altitude carbon monoxide poisoning, anemia, or lung disorder. Neurons are able to maintain some anaerobic metabolism, and they can tolerate some level of hypoxia. However, if this is more severe or more prolonged, then this can result in manifestations that range from listlessness and drowsiness to unconsciousness and convulsions. Ischemic injury is a result of reduced blood flow, leading to critically reduced oxygen and glucose levels. It can be focal or due to localized ischemia, as might occur with a stroke, or it could be global or widespread, in which blood flow is inadequate to meet the needs of the entire brain, such as might occur with a cardiac arrest. And this would rapidly lead to unconsciousness. Another form of injury is excitatory amino acid injury, and this occurs when we have prolonged ischemia that leads to the depletion of ATP and the inappropriate release of glutamate. Glutamate then initiates cell damage by allowing the influx of calcium, which then triggers a calcium cascade that includes things such as release of intracellular enzymes, breakdown of protein, free radical formation, a lipid peroxidation, and nuclear breakdown, which can lead to brain cell injury and even death. This type of injury is caused by acute events such as stroke, hypoglycemic injury, trauma, or chronic degenerative disorders such as Huntington's disease. Number 4, cerebral edema, is when we have an increase in tissue volume secondary to abnormal fluid accumulation. This can be vasogenic, which is the result of impaired function of the blood-brain barrier. This allows proteins to leak into the interstitial space. This can occur as a result of hemorrhage, brain injury, or infection. Or cytotoxic edema, which results in an increase in intracellular fluid. And this can be the result of hypoosmotic states or severe ischemia that impair the functioning of the sodium-potassium ATPase pump. And this can lead to, this cytotoxic edema can lead to cell rupture and damage to neighboring cells. Okay, let's talk about an increase in intracranial pressure. So the cranial cavity is composed of about 10% blood, 80% brain tissue, and about 10% cerebral spinal fluid. And these contents contribute to the intracranial pressure, which is normally pretty low, which ranges from about 0 to 15 millimeters of mercury. Now, because the brain is encased in a rigid skull, and these fluids, blood and cerebral spinal fluid, are not compressible, any increase in fluid or mass that could be the result of hemorrhage, edema, infection, tumors, too much cerebral spinal fluid, any of those things can lead to an increase in pressure, intracranial pressure, which, if uncompensated, can lead to brain injury and death. So how does the brain compensate for increases in intracranial pressure? And this is through the regulation of blood and cerebral spinal fluid volume. First, we can displace cerebral spinal fluid into the spinal arachnoid space, so from the brain ventricles down to the spinal arachnoid space. 2, we could increase absorption or decrease production of cerebral spinal fluid, so reduce less and absorb more. And number 3, we can limit the blood flow to the head. Now, this is going to be limited as cerebral blood flow is highly regulated, and an elevation of PCO2 in the brain is going to cause cerebral dilation and increased blood flow to the head. Now, if those above mechanisms are not enough to compensate for an increase in intracranial contents, then that increase in intracranial pressure can lead to life-threatening complications. For instance, as brain pressure approaches or exceeds the mean arterial pressure or perfusion pressure, then that's going to lead to tissue hypoxia because we can't get new blood to the brain. It can also cause brain herniation and hydrocephalus. So figure A1, this shows the falx cerebri. This is folds of the dura mater that separates the two cerebral hemispheres. Number 2 shows the tentorium cerebelli, and this is folds in the dura mater that separates the cerebral hemispheres from the cerebellum. And then number 3 shows the foramen magnum. In figure C, we see brain herniation. Supratentorial herniation occur in the cerebral hemispheres above the tentorium cerebelli. And these brain herniation here leads to progressive and sequential signs and symptoms of ocular, motor, and respiratory function. And this shows 3 different types of supratentorial herniations. So number 1, there we are. This shows cingulate gyrus under the falx cerebri. So this is a sideways displacement. This one is a little less serious, although these all are serious. Number 2 is a transtentorial or central herniation. And number 3, this shows an uncal herniation of the temporal lobe into the tentorial notch. This includes the downward displacement of the cerebral hemispheres as well as the basal nuclei, diencephalon, and midbrain. And then finally, number 4 shows an infratentorial lesion or herniation, which is less common. This is located in the brainstem or below the tentorium, and it could occur superiorly or inferiorly. Hydrocephalus occurs when we have progressive enlargement of the ventricles, shown here, due to an abnormal increase in cerebral spinal fluid volume. There's 2 types, communicating or non-obstructive hydrocephalus. This is caused by either a decreased reabsorption and or an increased production of cerebral spinal fluid. This form occurs more often in adults. Decreased reabsorption occurs like post-meningitis. Overproduction is less common, and this can occur with a tumor of the choroid plexus. This type is usually slow of onset and results in ventricular enlargement and compression of brain tissue, but a normal cerebral spinal fluid pressure. Number 2, non-communicating or obstructive hydrocephalus occurs when there is some obstruction within the ventricular pathway through which the cerebral spinal fluid circulates. This could be due to congenital malformations, tumors, or scarring left over from meningitis, and this form occurs more often in children. This accumulation of fluid may lead to dilation of the ventricles, atrophy of the cerebral cortex due to that pressure of all that fluid in the ventricles pressing on the brain tissue. Can also lead to degeneration of white matter tracts and an increase in intracranial pressure. In infancy, the skull is able to expand, so there are no signs of increased intracranial pressure, they may be absent, and there may be no long-term decline in intellectual function. These kids, though, may be a little irritable, and they may present also with seizures. In adults and children, head enlargement does not occur because the plates have fused. And if we have an acute onset of hydrocephalus, this can lead to signs and symptoms of an increase in intracranial pressure, which can result in a long-term neurological dysfunction, and if untreated, can lead to brain herniation and death. In traumatic brain injuries, we'll differentiate between primary and secondary brain injuries, and talk about the difference between contusions, concussions, and diffuse axonal injury. We'll also differentiate between epidural, subdural, and intracerebral hematomas. Traumatic brain injuries can be caused by motor vehicle accidents, most often in younger people, bicycle crashes, sports injuries, falls. Falls occurs more often in the elderly. Assault, shaken baby syndrome, and a variety of other things. The result of physical forces associated with this head injury can result in skull fractures, brain injuries, as well as vascular damage and bleeding. Because the brain floats freely in cerebral spinal fluid, blunt force to the head can cause the brain to accelerate within the skull and then decelerate abruptly. And this can cause brain tissue and blood vessels to be bruised and torn. So let's look at acceleration-deceleration injuries. A front and back injury includes the coup injury, and that's the site of the blow. In this case, it would be the frontal lobe. And the contra-coup injury, this is the area of the brain on the opposite side, contralateral to the site of direct damage. So as the brain accelerates and hits this, and then it bounces back, hits on the windshield here, the frontal lobe, and then as the brain bounces back, the occipital lobe hits against the back of the skull. Rotational injury occurs due to rotational motion of the cerebral hemispheres in the anterior-posterior plane around the brainstem, which is fixed. And this causes disruption of electrical and cellular activities of neurons in the reticular activating system. The effects of brain injuries can be divided into two categories. The primary injuries, these are the direct injuries, such as laceration or compression of brain tissue, rupture or compression of blood vessels, movement of lobes against each other, focal lesions, including contusions or bruises and hemorrhage, and diffuse injuries, including concussion and diffuse axonal injury. Secondary injuries are a result of the additional effects of, say, ischemia, cerebral edema, bleeding, or an increase in intracranial pressure. So a contusion is a bruising of the brain surface or a laceration of the brain tissue. We're talking about a contusion in the brain, of course. And this is caused by direct force or a skull fracture that's depressed, or acceleration-deceleration injury. Now, the manifestations that you see are going to depend on the size. Small, one-sided frontal lesions could be asymptomatic, whereas larger lesions are going to result in neurological deficits. Also, this resultant cerebral edema can lead to an increase in intracranial pressure, herniation, and even death. A hematoma is the result of injury to blood vessels and bleeding. And the type of hematoma is categorized by the compartment in which the bleeding occurs. If it's an epidural hematoma, that means that we have bleeding in the epidural space, subdural in the subdural space, and intracerebral, this is going to be blood within the brain tissue itself. So let's talk about epidural hematoma. So once again, it's the bleeding between the dura and the skull, and it's usually the result of a torn meningeal artery associated with a skull fracture. Because it's a torn artery, usually, it causes very rapid bleeding. Epidural hematomas are usually characterized by a brief period of unconsciousness, followed by a lucid period, which then rapidly progresses to unconsciousness. Now, this lucid period does not always occur, but when it does, it's a good diagnostic indicator. Focal symptoms of injury are going to be related to the area of the brain affected. So symptoms may include ipsilateral pupil dilation, so on the side of the lesion, and bleeding, and contralateral hemiparesis from an uncal herniation. If the hematoma is removed quickly, prognosis is good. Untreated, though, this can rapidly progress to an increase in intracranial pressure, brain herniation, and death. A subdural hematoma, we have bleeding between the dura and the arachnoid. And this is usually the result of tearing of bridging veins on the surface of the cortex of the brain to the dural sinuses. It is classified based on the time before the appearance of symptoms. Acute occurs less than 24 hours. Symptoms occur less than 24 hours. This one has a really high mortality due to edema and an increase in intracranial pressure. Subacute occurs about 2 to 10 days after injury, and chronic occurs several weeks after injury. Chronic may occur in elderly people, and because brain atrophy can allow more space to for the hematoma to grow before it causes a real increase in intracranial pressure. Intracerebral hematomas occur when small cerebral blood vessels rupture and bleed into brain tissue, or as a result of severe motion or contusion. This type of injury occurs more frequently in the elderly and alcoholics. It may develop days after the original trauma. This expanding mass from the bleeding can increase intracranial pressure, compress brain tissue, cause edema, leading to decreased level of consciousness, increased intracranial pressure, and brain herniation. A concussion is a mild traumatic brain injury. It is a transient alteration of brain function following a blow to the head or acceleration-deceleration injury. This may cause a momentary loss of consciousness. Post-concussion syndrome results in headache, irritability, insomnia, poor concentration, and memory, and this can last for months after the concussion. Multiple concussions can lead to cumulative damage, leading to alterations in behavior and cognition, and even movement years to even decades later. Second impact syndrome refers to a second head trauma while you're still recovering from a recent concussion. This can cause severe edema and has a fairly high morbidity and mortality associated with it. Let's talk about the manifestations of brain injury. Local or focal manifestations of brain injury include signs related to that specific area of the brain or spinal cord in which the lesion is located. For example, weakness or paralysis of the right arm is due to damage to a section of the left frontal lobe. Expanding lesions, like due to a tumor or bleeding, have additional impairment as adjacent areas become involved. Diffuse or global brain injuries always result in decreasing levels of consciousness, and this can range from simple inattention to lethargy to stupor, coma, or even death. Diffuse or global brain injuries also result in alterations of sensory, motor, and cognitive function. So let's look first at focal injuries. For instance, if we have damage to upper motor neurons, then we'll see weakness or paralysis on the contralateral side of the body. Damage to lower motor neurons lead to weakness or paralysis on the ipsilateral side of the body at and below the level of the spinal cord damage. Damage to the somatosensory cortex in the parietal lobe is going to result in sensory deficits involving touch, pain, temperature, and body position, and damage to the temporal lobe could result in deficits of hearing, taste, and smell, while damage to the occipital lobe could result in damage to vision. So let's first look at visual disorders. So this is going to depend on the site of damage within the visual pathway. For instance, if we have damage to the optic chiasm, if it's totally destroyed, we see that we lose all those nerve fibers, and we're going to lose vision in both eyes. A partial loss would depend on which fibers are involved. If we have damage to the occipital tract or the occipital lobe, say here on the left side, this is going to result in the loss of visual field on the opposite side, or a loss of the right visual field. This here describes no vision is illustrated in white with different lesions. So let's take a look at this. If we had damage here to the right optic nerve coming out of the eye, then we would lose all sight from that right eye. The left eye, though, would give us information about both the left visual field, shown in blue, and the right visual field, shown in red. Lesion 2 at the optic chiasm, this is only the fibers that cross over, which are the fibers that give us information about our temporal field of view. So with lesion 2, we would see that we have lost our left temporal and our right temporal field of view, but we have our left nasal view and our right nasal view. So this is going to give us kind of a tunnel vision. Lesion 3 is to the right optic tract, and this is going to cause loss of the left visual field in both eyes. But we have the right visual field still present in both eyes. Language disorders. Aphasia refers to the inability to comprehend or express language. Expressive or motor aphasia, this is where you cannot speak or write fluently or appropriately, and this is going to be due to damage to Broca's area, which is found in the frontal lobe, usually in the left frontal lobe of most individuals. Receptive or sensory aphasia is the inability to read or understand the spoken word, and this is due to damage to Wernicke's area, which is found in the temporal lobe and in the left side in most people. Global aphasia refers to a combination of both expressive and receptive aphasia. Fluent aphasia is where the pace of speech is normal but includes made-up words, and this is associated with damage to Wernicke's area. Non-fluent aphasia, we have slow and labored with short phrases, and this is associated with damage to Broca's area. Dysarthria, this is where words cannot be articulated clearly, and this can be due to cranial nerve damage or muscle impairment in the face or tongue. One of the manifestations of global brain injury is changes in the level of consciousness. This table describes descending level of consciousness and their characteristics. You do not need to be able to define the difference between, say, a stupor or delirium, but I just wanted to point out that changes in the level of consciousness almost always occur with diffuse or global brain injuries. Okay, so what are some other manifestations of deteriorating brain function? Pupillary reflexes. As I mentioned earlier, the pupils normally are reactive and constrict in response to light. But as brain function deteriorates, the pupils can become unreactive and dilated. A bilateral loss of pupillary light response indicates brainstem lesions. Unilateral loss may be due to a lesion of the optic or oculomotor pathways. The oculocephalic reflex is a test to see if the brain's stem centers for eye movement are intact in a comatose person. And this is illustrated right here. So if you take somebody's head that's comatose and turn them, if the brainstem is intact, the eye gaze moves in the opposite direction, like a doll's head. If the brainstem function is not intact, the pupils stay fixed in mid position. Oh, and this figure shows an eye that's dilated and fixed, not responsive to light, whereas this eye is. Okay, some other manifestations of deteriorating brain function. Respiratory responses. Early, we can start seeing yawning and sighing. This can progress to Cheyne-Stokes breathing, which has a waxing and waning of respirations and periods of apnea. As it moves, as damage moves down to the midbrain, like with herniation, we can get neurogenic hyperventilation. And then as we have more progression to the medulla, we can get ataxic breathing. And this is totally uncoordinated and irregular breathing with a lack of response to hypercapnia. Some other manifestations of deteriorating brain function include abnormal posturing or positioning. Decorticate posturing is where we have abnormal flexion. So we have rigid flexion in the upper limbs with adducted arms and internal rotation of the hands. This indicates severe damage to cerebral hemispheres or the cervical spinal tract. Decerebrate posturing is when we have abnormal extension. And here the upper and lower limbs are extended, head is extended, body is arched. And this indicates brainstem lesions and central nervous system depression caused by systemic effects. Okay, moving on, we're going to talk about cerebrovascular disorders. Cerebrovascular disorders can lead to problems with a blood supply, and this can cause local damage and manifestations related to which cerebral artery is involved. It can also cause hemorrhage, and that can lead to an increase in intracranial pressure, local ischemia, and generalized symptoms. And global cerebral ischemia is when we have impaired perfusion of the entire brain, and this leads to a loss of function and generalized cerebral edema. This quickly leads to brain death if not reversed. Cerebral vascular accidents, also known as stroke, are the third leading cause of death in the United States. It's also a major cause of disability. Cerebral vascular accident is essentially an infarction of brain tissue due to result of lack of blood and oxygen. An ischemic stroke is one that's caused by occlusion of blood vessels, usually by a blood clot that blocks an artery or by the rupture of an atherosclerotic plaque and the formation of a thrombus. A TIA, which we'll talk about later, may be a precursor for a stroke. A hemorrhagic stroke is one where the blood vessel has ruptured. Nerve cells can't last very long without oxygen, so about 5 minutes of ischemia can lead to irreversible nerve cell damage. Compare that to in cardiac myocytes, which can tolerate closer to 20 to 40 minutes of ischemia. So within about 5 minutes, we have a central area of necrosis, and all function is lost in that area. But we also have the surrounded area of inflammation, and that zone can regain function following healing. All right, this shows some of the risk factors for stroke. Some modifiable factors potentially include high blood pressure and high hyperlipidemia, smoking, diabetes mellitus, heart disease including atrial fibrillation and wall motion defects. These are things that are more likely to cause an embolus. Coronary artery disease, coagulation disorders, obesity and activity, heavy alcohol use and cocaine use. Some unmodifiable factors include increasing age, male gender, race with African Americans being at higher risk, and hereditary. Ischemic stroke is the most common type of stroke, making up about 85%, and it results from a diverse set of causes of cerebral vascular obstruction by either a thrombus or an embolus. They're classified by cause. Okay, so number one, we have large artery atherosclerotic disease. This is where we get thrombosis and perhaps arterial emboli. They make up about 20%. Small vessel or penetrating artery disease, lacunar stroke, makes up about 25%. Cardiogenic embolism, so this is where an embolus is formed in the heart and then we throw it to the brain, makes up about 20%. About 30% we have undetermined cause, and about 5% are due to other causes such as like coagulation abnormalities. Transient ischemic attacks result from a temporary localized reduction of blood flow in the brain, leading to a transient episode of impaired function. So you could kind of compare a TIA to a CVA as like angina is to a myocardial infarction. So this is going to result in transient manifestations related to the area of injury. For instance, muscle weakness in an arm or leg, visual disturbances, numbness, and paresthesias in the face, aphasia, or confusion. Once upon a time we had a time window for what we would call a TIA, but now that's defined without limits. So the time period of ischemic impairment is without limits, but the definition of a TIA is that it doesn't result in tissue infarction, and the manifestations eventually go away. They're transient. Repeated attacks of TIAs can be a warning sign for ischemic stroke related to atherosclerosis. So just like angina could be a warning sign of heart attack, a TIA could be a warning sign for a stroke. Large vessel or thrombotic stroke. This is where we have arterial occlusions by the formation of thrombi in atherosclerotic arteries that supply the brain or in intracranial vessels. This is not associated, and here it's showing some of this, it's not associated with activity and can occur in people at rest. These often affect the cortex, resulting in aphasia if we have damage to Broca's area or Wernicke's area, and motor sensory damage, motor frontal cortex, sensory parietal cortex. And we would see the sudden, depending on the area of the brain involved, we would see a sudden weakness or numbness of the face, arm, or leg on one side of the body, or maybe trouble speaking or understanding spoken word, or visual problems if it leads to impaired blood flow to the occipital lobe, difficulty walking, loss of balance, coordination, severe headache. These types of strokes most often occur in older people and are usually accompanied by coronary artery disease and or peripheral artery disease because that just suggests generalized atherosclerosis. Small vessel stroke, also called lacunar infarcts, involve small penetrating branches of cerebral arteries rather than like the large cerebral arteries. And this is the result of occlusion of these branches. Infarcted tissue will scar, and it leaves these cavities or lakes, and that's where the name comes from. This is the result of arterial sclerosis in patients with chronic hypertension and or diabetes mellitus. It does not produce cortical deficits because it involves deep non-cortical tissue, but instead produces other syndromes, including motor hemiplegia, sensory hemiplegia, dysarthria, or clumsy hand syndrome. Small vessel strokes, also called lacunar infarcts, these are the most common, and these involve infarction of tissue in deep non-cortical tissue in the brain or brainstem as a result of occlusion of small penetrating branches of cerebral arteries. So not one of these large vessels, but one of these branches. And it doesn't involve the cortex, rather it involves tissue deep to the cortex. So the infarcted tissue scars, leaving these small lakes or cavities. These are the result of atherosclerosis in patients with chronic hypertension and or diabetes mellitus. They don't produce specific cortical deficits because it doesn't involve the cortex, but instead they produce lacunar syndromes such as a pure motor hemiplegia, so that would be motor only, motor weakness or motor paralysis on one side of the body, or a pure sensory hemiplegia, which is going to be less common than the motor. It can also involve dysarthria or clumsy hand syndrome. An embolic stroke. The most frequent site for this is the middle cerebral artery. Most of these emboli originate from the heart due to blood clots forming due to atrial fibrillation, rheumatic heart disease, and bacterial endocarditis, so these vegetations can break off. Recent myocardial infarction, where the heart is not pumping efficiently and blood is allowed to clot. Ventricular aneurysm, where there's a, not shown here, where there's a kind of an outpouching of the ventricle and blood kind of pools and is allowed to clot there. They may also originate in atherosclerotic plaque in the carotid arteries, and then a piece of this plaque breaks off and becomes an embolus. Because it's an embolus and it suddenly blocks blood flow, it's going to result in a sudden onset with immediate manifestations. A hemorrhagic stroke is caused by a spontaneous rupture of an intracerebral blood vessel, and this is going to result in a hemorrhage into the brain tissue, intracerebral hematoma, and impaired cerebral perfusion, okay, because we just lost a lot of blood from that blood vessel, leading to tissue infarction. The onset is sudden, and it's usually associated with activity. Some risk factors or predisposing factors include increasing age and hypertension, which is the most common. Other factors are ruptured aneurysm, trauma, and erosion of blood vessels by tumors. Signs and symptoms of a hemorrhagic stroke include vomiting and headache, okay, because we have all this, an increase in intracranial pressure. Focal symptoms are going to depend on the area of the involved brain tissue, but most commonly we have bleeding into the basal ganglia that results in contralateral hemiplegia with flaccidity progressing to spasticity. The hemorrhage and the resultant edema can also cause a rapid rise in intracranial pressure, and that can lead to brain herniation, coma, and death. This is the most frequently fatal type of stroke with the worst prognosis. The clinical manifestations of a stroke are going to depend on what is the artery affected and the brain area served by that artery. So it's going to depend on not only location, but also the size of the artery and what is the function of that area. The presence of collateral circulation, which can occur in some thrombotic strokes, may help to diminish the size of the affected area. So that's another factor. Common signs of stroke include contralateral muscle weakness or paralysis. This is flaccid initially and then spastic. Contralateral sensory loss, aphasia if it involves the left hemisphere, and impaired spatial relationships if it involves the right side. Occlusion of larger arteries that provide a broad area of the brain or hemorrhage may cause more severe and widespread effects such as loss of consciousness, coma, and death. Cerebral aneurysms occur when we have a localized weakness in the wall of an artery. They are usually found at points of bifurcation, or points where we have branches, particularly on the circle of Willis. Things that can lead to these include congenital defects, so weak vessels, atherosclerosis, hypertension, bacterial infections, arteriovenous malformations, and polycystic kidney disease. Small aneurysms can be asymptomatic. So, in fact, a large number of intact aneurysms are found on autopsy. Large aneurysms can cause a chronic headache and neurological deficits. If we have a slow bleed, that can cause sudden severe headache, nausea, vomiting, and dizziness. Rupture and large bleed leads to subarachnoid hemorrhage, increased intracranial pressure, and death. A ruptured aneurysm can bleed into the space between the arachnoid and pia, resulting in a subarachnoid hemorrhage. Signs and symptoms include severe headache, confusion, and decreasing levels of consciousness. You get nuchal rigidity or neck stiffness, and this is due to irritations of the meninges, photophobia, diplopia, and blurred vision, and this is due to cranial nerve defects. You can get focal and motor sensory deficits, cerebral edema and an increase in intracranial pressure, vomiting and seizures, and loss of consciousness as a result of a massive rupture, which can be followed by brain herniation and death. Okay, let's move on to infections, brain tumors, and seizure disorders. Meningitis refers to inflammation of the meninges of the central nervous system. Bacterial meningitis in children and young adults is usually caused by meningococcus, which is frequently carried in the nasopharynx of asymptomatic carriers and is spread by respiratory droplets. In older adults, is usually caused by Streptococcus pneumonia. This bacterial meningitis may be secondary to other infections such as otis media ear infection, or may be the result of an abscess, for instance, an abscessed tooth. It can cause inflammation that leads to an increase in intracranial pressure and edema of the pia and arachnoid layers. And you can get this pussy exudate that covers the brain, shown as kind of this whitish stuff there. Signs and symptoms of meningitis include a sudden severe headache, back pain, photophobia, nuchal rigidity, which is a hyper-extended and stiff neck, vomiting, irritability, lethargy, fever and chills with leukocytosis. And this can progress to stupor and seizures. The petechial rash, that's those pinpoint like bleeding due to rupture of capillaries. This occurs all over the body. Some complications of meningitis include hydrocephalus, cranial nerve damage, permanent neurological deficits, and death. Diagnostic tests. We can examine the cerebral spinal fluid, which is going to be obtained by a lumbar puncture, to identify the causative organism. Treatment is with aggressive antibacterial therapy. Treatment measures for intracranial pressure and seizures if needed. Glucocorticoids to reduce inflammation and edema. Vaccines are available for some types of meningitis. In fact, my daughter going off to college will be receiving some of these soon. Viral meningitis is much less serious usually and resolves on its own, and it can be caused by enterovirus, influenza, mumps, and measles. Encephalitis is infection of the parenchymal or connective tissue, so the brain tissue in the brain and the spinal cord. This can result in necrosis and inflammation within the brain and result in permanent damage. Infection may include the meninges. It's usually of viral origin, but it may be due to other organisms. So West Nile fever is an example of a viral example. Lyme disease, for a bacterial origin. Herpes simplex is another viral. Early signs include a severe headache, stiff neck, lethargy, vomiting, seizures, and fever. Brain tumors are space-occupying lesions that can cause an increase in intracranial pressure. So both benign and malignant tumors can be life-threatening unless they're easily accessible and removable because of this increase in pressure. Gliomas, these are tumors of the glial cells, and they are the most common type of primary malignant brain tumor, and they're classified according to the cell which they're derived from. For instance, astrocytomas. Tumors of the meninges or pituitary gland can also cause similar neurological effects. So primary malignant tumors, these rarely metastasize outside of the central nervous system. They usually have no well-defined margins. They are invasive, and they have irregular projections into adjacent tissue. Okay, they're malignant. They're difficult to totally remove, and they usually have inflammation around the tumor. Secondary brain tumors, these metastasize from usually breast or lung tumors, and they cause effects similar to those of primary brain tumors. Signs and symptoms. At the site of the tumor is going to determine the focal signs, what part of the brain is affected. Seizures are often a first sign, headaches due to increased intracranial pressure, vomiting, lethargy, irritability, as well as personality and behavioral changes. You can have unilateral facial paralysis or visual problems due to damage on the side that's affected. They do not cause any systemic signs of malignancy because they usually cause death before they cause general effects. Treatment may cause damage to normal central nervous system tissue. Surgery is an option if the tumor is accessible, and then chemotherapy and radiation if it's not. Okay, finally, seizure disorders are caused by spontaneous excessive discharge of neurons in the brain due to inflammation, hypoxia, bleeding, or these could be due to epilepsy. A focal seizure begins in a specific area of one cerebral hemisphere. And this area of the hemisphere is the area that's been irritated, say, by the bleeding or the inflammation. This can occur with or without impairment of consciousness. It may become generalized, in which it involves both hemispheres. A generalized seizure, we have both hemispheres involved at the onset and a loss of consciousness. Absent seizures or petit mal seizures, these are non-convulsive epileptic events where there's just a momentary loss of consciousness. Tonic-clonic or grand mal seizures can include a tonic phase of muscle contraction, followed by a clonic phase in which we have bilateral contraction and relaxation of the extremities. Continuous seizures or status epilepticus is where the seizure keeps continuing, and this is a life-threatening condition.